very much. I hope everyone can see my presentation. Okay. So Boy Sang To Lang, thank you for inviting me to speak at the Radiology Society of Cantor Annual Radiology Conference. It's wonderful to be here on Zoom and see some friends again. I hope to be there in person soon and not on the screen. For those who I haven't met, I have been lucky enough to travel to Cantor 3 times in my role as a lecturer in medical sonography for Central Queensland University. I was also thrilled to attend the celebration of 40 years of construction and development of CTUMP in December 2019. I've been in my role as a lecturer at the university for nearly 7 years, and before that, I worked as a sonographer and a radiographer for around 25 years. In that time, I've performed both mammography and breast ultrasound. And today I'll be talking to you about how ultrasound and elastography is used in imaging of the breast and breast cancers. So what I'll be talking about is imaging the breast with ultrasound, which includes B mode, Doppler, and elastography, of course. I'll talk about how to scan a breast, the patient care, patient positioning, and scanning techniques. We'll talk about BIRADS and how that's used in ultrasound and how elastography is now being included. And also we'll do some examples of breast carcinomas at the end. So breast ultrasound is done in conjunction with mammography in many cases. In Australia, women are screened for breast cancer from the age of about 50 with mammography. Ultrasound is also utilised in the screening program to further assess any masses that might be demonstrated on a mammogram. Symptomatic women with palpable breast lumps of any age are also offered mammogram and/or ultrasound to assess the nature of the mass. The decision on whether a woman will have a mammogram or an ultrasound will depend mainly on the age of the woman. Most often, young women with dense fibroglandular tissue will have an ultrasound as the first option, as it provides better resolution of this dense breast tissue than mammography does. Older women with more fatty replaced breasts will often have a mammogram first and perhaps a follow-up ultrasound. So ultrasound can offer further diagnostic information on malignant masses that are also demonstrated on mammography. It's also a valuable standalone diagnostic tool, as I mentioned, for younger women under 35 and also pregnant or lactating women. It's also used for ultrasound guided biopsy. So this image is from the website Radiology Assistant, and it demonstrates very nicely how the breast appears at different ages throughout a woman's life, and how ultrasound in younger women demonstrates that fibroglandular tissue and any potential masses within it more effectively than mammogram. And as a woman becomes postmenopausal and the glandular tissue is replaced by fat, mammogram becomes a little bit more effective. So when a woman presents for the investigation of a breast lump, it's often an anxious time for the patient. Patient-centered care is important for these times to ensure the patient can provide a thorough history and reduce the heightened anxiety. So sometimes a woman might actually answer to an incorrect name or give you incorrect information because of this anxiety. So sometimes it's beneficial to double check their name or just repeat instructions and things like that. It also helps to have the room ready for the ultrasound, and having a reassuring manner will save some time and also go a long way to relaxing the patient. The type of ultrasound machines we use are generally the high end, so the best ultrasound machines that we have in a department, and we use a linear transducer with high frequency. So this is an ultrasound probe that we use at the university, although I do like GE ultrasound equipment. So this probe, a transducer, goes from 4 to 22 megahertz. And it's also capable of elastography. So this is the type of equipment that we need. And I did like the GE equipment that was on at the beginning of the presentation. So to actually scan a breast, the patient will be supine on the table with the side of interest rolled up and support under that shoulder. So the woman will be slightly oblique. And the arm of that breast will be raised up above their head. And this will flatten out the breast against the chest wall and make it easier to scan. And having the arm out of the way will make it easier of access to the breast. Some large breasts can be difficult, and you may need to vary the patient position. Breasts that are scarred from surgery or biopsy may also require different techniques as well. It's also can be difficult underneath the nipple, so the retroareolar area, you may need to angle around there as the nipple does cause shadowing beneath the nipple. So we use a variety of techniques of actually scanning a breast. So one of the common ones is this grid technique here. Just get a laser pointer. So we move from the lateral to the medial side of the breast, going all the way down the breast, and then from the superior aspect to the inferior aspect of the breast all the way along there as well. It's important that there is overlap in between the different sweeps to ensure that you see all the breast tissue. The other technique we use is radial, so we scan in circles going around the breast until the entire breast is covered, and also anti-radial, so that is going from out the extremity of the breast in towards the nipple and then going in and around the breast that way. And again, always ensuring that you get that overlap. And if the scan is being performed because a woman does have a lump that she can feel, I will often ask for consent to touch or to palpate the breast so that I can feel what the patient is feeling and I know that I'm scanning in the correct area and seeing what they can see, what we can see. So imaging the breast with ultrasound, traditionally we've always used B-mode ultrasound and Doppler, of course, to have a look at the vascular structures. And in more recent times, we've been using elastography as well to give that extra feature to the tissues. So I won't go into the B-mode and Doppler too much. I'm sure you understand the physics and how it works. But the B-mode imaging of the breast will give you lots of information as to the features of the masses and whether they're benign, give you an idea as to whether they're benign or malignant. The Doppler will demonstrate vascular supply. So often our breast carcinomas do have a vascular supply. So you will see colour Doppler within the mass. And elastography measures the mechanical properties of the mass and tells us whether that mass is hard or more soft. And it is becoming a more used tool to have a look at these and evaluate these masses. So when we're using elastography, there's two types that we can use. There's strain elastography and also shear wave elastography as well. And often both types can be used, and it is being noted that using both types of elastography does actually give better results in the evaluation of these masses. So the strain elastography uses a manual compression of the transducer. So the operator will need to push down with the probe onto the mass, and then the ultrasound machine does its calculations to give a colour overlay of the mass on the screen. The dynamic form of strain elastography actually uses internal, external harmonic stimulus. So it might be the patient breathing causes the pressure for the machine then to be able to decide whether this mass is hard or soft. So as you can see here, it doesn't give us any quantitative information, it only gives us qualitative information. And you use the scale down the side here to decide whether this is hard or soft. So the blue represents hard tissues and the red and the yellow is the more soft tissues along here. So this is actually a phantom, but this mass is obviously a hard mass there. So shear wave elastography actually uses a pulse that's applied into the tissue, and it induces a shear wave perpendicular to the beam. And so the ultrasound machine calculates the speed of the wave going through the mass and demonstrates both qualitative and quantitative information. So we've got here, you can see how it's giving that colour overlay like it does with strain elastography. But it also gives us some measurements here as well. So you can actually give a quantitative result as to whether this is a hard or a soft mass. So these are the types of breast carcinomas that we can demonstrate on ultrasound. But what's important to note is that specific differentiation must involve a number of investigations. For example, a biopsy, because the diagnosis itself is not based on ultrasound alone. So if you do see a suspicious mass on ultrasound, it does need further investigations so that we can say whether it is, for example, a medullary carcinoma or a carcinoma in situ, for example. So when if we do come across a mass within a breast, we need to take note of the sonographic features. So most of these you'll notice on B mode, and then of course we've got the elastography there as well. So when we're characterizing a mass, we think about the shape of the mass. So a carcinoma can look quite irregular. It won't have the nice smooth round oval shape. And you also have a look at the shape of, on top of the shape, it's actually whether the mass is taller than wide. So if the vertical plane of the mass is longer than the width, that's another suspicious characteristic of this mass. And we also have a look at internal echoes. A carcinoma will appear quite irregular within, so there'll be lots of different echo values. So there'll be bright echoes and dark echoes, whereas a benign mass will look more homogeneous, so quite smooth throughout with the black and white scale. We also have a look to see whether the mass has any enhancement below it. So if there is a dark, or if the imaging below the mass is sort of obliterated, so you get the acoustic shadowing, that can be a sign of carcinoma. But if it is actually enhancing and the tissues behind it are brighter, that can actually be a sign of more of a benign mass. We also have a look at whether it's disruptive. So we look at the margins and we see whether it's nice and clean and clear from the surrounding tissues. But if it's not, if it's indistinct, or fuzzy is another word I sometimes use, that's another suspicious sign that this could be a malignancy that we're looking at. And of course, we have a look at the elastography, or whether it's compressible, so whether it's a stiff or hard mass, or whether it's on the more softer edge of the spectrum. And all these descriptions are what we can use to help when we're categorizing lesions with BI-RADS. So I'll talk about BI-RADS next. So this is the current edition, so it's the 5th edition of BI-RADS. So BI-RADS standardizes the descriptors of breast masses for mammography, ultrasound and MRI. In this most recent edition, elastography has actually been added as one of the descriptors for BI-RADS. So as you're making your assessments of the masses, you can add in whether the mass is coming up as soft, intermediate or hard, or the more stiff, which will help in the categorizing of the mass and how you're going to manage that mass from there on in. So once you've been able to describe and use all these descriptors, it then puts the mass into a category, anywhere from 0 up to category 6. And 0 to 3 is most likely benign, so you'll have a specific type of management for that particular mass, and some will require follow-up and some may not. And then as you get into category 4 and 5, this is when there is definitely going to need to be follow-up. So whether there's going to be further imaging or a biopsy of that particular mass. And what Covington is saying quite recently, I read a paper from March 2022, is that elastography is helping the categorization between categories 3 and 4. So adding the characteristic of the stiffness of the mass can help with these categories, and then decide whether the patient needs to be followed up more aggressively, or whether it can be more of a softer follow-up and perhaps only just a follow-up ultrasound in 6 months or something along those lines. So elastography is helping the categories between category BI-RADS 3 and BI-RADS 4. All right, so I'll go into a couple of examples. This very first example is obviously a fairly obvious mass that's been demonstrated on ultrasound just underneath the skin. So as we're looking at this mass, the things that we need to consider are what I spoke about before. So we're thinking about the shape. This shape is very irregular. It's not round or oval. And this is the taller than wide. So this measurement here, the vertical plane here, is longer than coming across the mass there. So that is quite a suspicious feature of this mass. You can see almost like a white line, or called a halo, around this mass as well. That is also another concerning feature of this particular mass. And the margins a little bit indistinct coming around here as well. You can see that and also on the Doppler here as well, there's no enhancement behind this mass, and in fact it's probably shadowing here, so that mass is absorbing a lot of the echoes that are coming into it. And also, talking about the echoes that are coming into it, you can see it's quite irregular in there, so it's not smooth. We've got a variation of more bright echoes as well as a very dark echoes that are absorbing the sound. And we put Doppler on this mass, you can see quite obviously some internal vascularity within this mass. So this is a very suspicious mass and would definitely require further investigations. And after a biopsy, this result would come back as invasive lobular carcinoma. And we have another mass here. We've used elastography on this one. Again, we're looking at the B mode characteristics of this mass. We can see that it's taller this way, so the vertical plane is longer than it is across here. It's hypoechoic, but again, it's irregular, and there you can see different, it's not homogeneous through here. We can see brighter echoes and darker echoes, and even a tiny little cystic component in here. We've got that white line or the halo around the mass there again. And as we put the strain elastography on top of that mass, you can see this area here, which corresponds to the mass, is quite blue, which according to this scale is hard. So it's definitely hard. You wouldn't even put that into intermediate. It's definitely a hard or stiff mass compared to the surrounding tissues around that mass. So this is very suspicious for malignancy and would definitely need follow-up. And after biopsy, this one came back as an invasive ductal carcinoma. So the last mass here, this one's to demonstrate that not all masses have these very obvious characteristics, and scanning breast masses takes a lot of practice and a lot of knowledge. And certainly in Australia, we've got very specialist breast sonographers and radiologists who do these scans. So in this particular mass, it's not that irregular shape that we saw with the other two, it's more round. So the shape of it is not as suspicious as the others. It's a little bit irregular though. I mean, it's not a nice smooth border, so the borders are looking irregular and fuzzy. The internal echoes are not homogeneous either. So we've got different, we've got brighter echoes, darker echoes, and again, this cystic area there as well. The one thing that might put you off to think, oh, maybe it's not malignant, is the fact that it actually does have posterior enhancement. So the tissues behind this mass are brighter. So that's not a sign of malignancy. But as I said, not all the masses play by all the rules, unfortunately, which makes our lives a little bit more difficult. There's only, so we put Doppler on this one, there's only a tiny demonstration of colour Doppler there, so a little vascularity. So it's not really obvious that there's a vascular supply there. But it did have enough concerning features that it did need follow-up, according to BI-RADS. And this one came back as a mucinous carcinoma, which is rare, but it's a type of IDC. So it was definitely, it's good that this finding was good for the patient, because it could be followed up and hopefully had a good patient outcome. So to summarise, breast ultrasound is a valuable diagnostic tool in the process of diagnosing breast carcinoma. The masses demonstrated with ultrasound or the suspicious masses will need following up with imaging, other imaging or biopsy, and differentiation of the carcinoma requires further investigation after ultrasound as well, so we can tell what type of cancer it is. BI-RADS is a very effective method to describe and categorise breast masses, and then makes management of the patient fairly straightforward. And elastography is proving to be worthwhile mode to further categorise breast masses, and is proving to be to assist in categorising between BI-RADS 3 and BI-RADS 4. So yes, breast ultrasound, as I mentioned, does take a lot of practice and it does take some time as well, particularly when you're bringing elastography into the examination. It does add on to the time that you will be spending doing the scan. So these are my references, and I just wanted to thank you for having me and asking me to present today. I hope I've been able to give you some information that will assist you in ultrasound of the breast. If you'd like any further information on breast ultrasound or any type of ultrasound, because I do like ultrasound, my contact details are here, and I always like to see an email coming into my inbox from Vietnam. And I really hope to see you in Can Tho soon, and I hope I'm standing underneath this sign in the next 12 months. Thank you very much.
Miss Jane, for your very